Today we will be discussing about airway assessment. So, when you just think about it, it is one of the basic topic which any anesthetist learn when the training is being started. Okay. So unfortunately, sometimes still our approach, our knowledge is not complete even for this topic. Okay. So Atik bhai, if you just can break the ice, how would you like to assess the airway? If you want to assess patient's airway, what should be your approach? Anyone, if Atik bhai is not um, Mauzama, Dr. Sadaf, anyone who wants to speak out? Nobody wants to speak out. Why airway assessment is important? Why would you like to assess the airway?
Hello.
Yes, Dr. Akshay.
To anticipate difficult intervention,
I request all of you to mute yourself, please. Yes, Dr. Akshay. To anticipate, because all our whatever anesthesia we are giving, it can collapse the airway. Okay. So so that's why it's very important that whatever anesthesia we are giving, even local anesthesia, um, even regional anesthesia, still we have to assess the airway. We got any point of time we need to maintain the airway because all our medications are affecting the airway. Okay, so that is the reason. So how to assess? Yes, Dr. Akshay, how would you like to assess the airway?
mouth opening.
Mouth opening. Okay, mouth opening will be one of the thing. What else?
Neck flexion, head extension.
Neck movement. Okay, what else?
Denture.
I'm sorry?
Denture.
Denture.
Hello.
Okay.
Denture.
Okay, what else? I will just interrupt you for a moment. Would you like to directly start examination, or some questions in history are more important to start with?
History of obstructive sleep apnea is also important.
History of obstructive sleep apnea. What else? Nasal
Any
obstruction.
history of yes.
Yes, who is speaking? Please continue. Yes,
Any
doctor.
history of previous surgery or radiation therapy
and the response of patient during
Just a second.
anesthesia.
Just a second, please. Dr. Sadaf, Dr. Arfa started, so let her speak and then I will. Because if two people will speak, nobody can understand anything. Yes, Dr. Arfa, please continue.
Thank you, sir. History of any surgery on the neck or any radiation therapy on the neck is also important.
Okay, radiation. What else? So this is also history that you will ask any artificial denture. Okay. What else? Only focus on history. Loose tooth. Artificial tooth. Okay. Pain in the neck.
Diabetes is also important because of the TMJ mobility and cervical involvement.
Okay. What else what if you speak out the diseases, so what other medical diseases can affect airway?
Rheumatoid arthritis.
Rheumatoid arthritis. What else?
Neck
Scleroderma.
contracture.
Okay. Connective tissue diseases. Acromegaly.
Post-burn contracture.
I'm sorry. Post
Thyroid.
burn. Post
Hyperthyroidism.
burn contracture. Only hyperthyroidism or hypothyroidism, both? Thyroid disease.
Ji, sir. Yes, sir.
Okay. What
Sir,
else?
Down syndrome. Down syndrome.
Upper airway tumor.
Down syndrome. Okay. So like that, you will be focusing on different, like it may be medical problems. It may be surgical problems. It may be just like dentures or braces or things like that. Okay. So your first question should be, and whenever we are talking about airway, it is both nasal cavity and oral cavity, and then neck. So you have to focus actually on three things. Okay. So another thing is that when you are assessing like airway, your focus is on three things, or you can combine. Actually, they are the same things, but you have to focus on mask ventilation. You have to focus on laryngoscopy, and you have to focus on intubation. Okay. So mask ventilation is one thing. Sometimes laryngoscopy is difficult. Okay. And sometimes laryngoscopy is being done. You can see it, but still you are not able to pass the tube. There may be a number of reasons for each of it. So you have to focus on all three things. So if you just think about mask ventilation, okay. So in mask ventilation, if you just divide in certain categories, so which patient will have difficult mask ventilation? Obese patient, bearded patient. What else? Edentulous patient.
Pregnant patient.
Edentulous. Pregnant. Okay. What else?
Elderly patients.
Elderly patient.
Patient with
Beard.
ECMO.
History of snoring.
Facial trauma.
Sir, there is a mnemonic known as MONS.
Facial trauma.
Dr. Akshay,
MONS.
unfortunately, if you can remove your, I think, headphones, because there is so much echo coming. Yes, Atik bhai, there are at least two mnemonics I know. This one is obese, which I have just written here. Obesity, bearded, edentulous, snoring, and elderly patient. So this is one of them. Other formula, what was it? What you were saying? MOAN?
MOANS. MONS.
Moans. Okay, so M for
difficult mask. For difficult mask
What is-
ventilation.
M for
Sir, M for mask, seal bird, या distorted anatomy.
okay.
O is for obesity more than 26 BMI.
Okay.
A is for age more than 55.
Okay.
N is for no teeth, edentulous.
Okay.
And S is for sleep apnea or stiff lung, ARDS.
Okay. Stiff lung or ARDS. Okay. Anyways, almost the same. You can remember any of them, and you can reproduce. Your main aim is to reproduce the things. Okay. So just a second. Okay, so we will just try to find out some of other reasons, like large tongue, epiglottis. This is called as kissing tonsils. In very big tonsils, they are like blocking the airway, and it is difficult to ventilate. Okay, abnormal anatomy like the edentulous, beard, upper and lower airway tumors, extrinsic compression of airway. One of them is the superior vena cava syndrome, and that once you give some anesthetic medication, you will not be able to ventilate. Okay, foreign bodies, pneumothorax, fistulas. You know, fistula, when there is fistula, there will be leak and you are practically not able to ventilate. Okay, and any chest wall deformity, previous neck radiations, and physiological reaction. Of course, when patient has laryngospasm or bronchospasm, still you will not be able to ventilate. Okay. Male gender, mask seal, we have like we know the basic concept that whenever there may be a number of formulas, a number of ways this can be described, but our main aim is to have the concept that whenever we are talking about difficult airway, it is not only intubation or laryngoscopy, it starts from ventilation. Okay, because the patient dies sometimes not because of intubation, so because of ventilation. Okay, so that is more important. Okay, because if you fail to intubate, still if you can have the ventilation, you can save the life. So similarly, like they have just explained a little in a little detail the same things: mandibular protrusion, age, snoring, weight, almost the same things. Okay, so now if we just focus that how can we like improve the mask ventilation, whatever problems we have, if we want to improve the mask ventilation, what are different ways to achieve those? Like troubleshooting of mask ventilation. Yes, please. Proper size. I'm sorry.
हेड टिल्ट करेंगे, चिन लिफ्ट करेंगे.
Okay, head tilt, chin lift. What else?
jaw thrust.
Okay, jaw thrust. What else?
Sir, the application of a particular face mask so that it should be make close
Like closed
seal.
sealed masks. Okay. Use of airway, nasopharyngeal airway. Okay, or oropharyngeal airway. Okay, what else? Achieving a proper depth of anesthesia. Sometimes this is a reason of not able to be ventilated. Then making ramp position, rapid airway management position. We have discussed a number of times, in which we bring the external auditory meatus at the level of sternal angle. Okay, we just elevate the head in a way, head and neck in a way that we are increasing the height of external auditory meatus, and we bring it at the level of angle of sternal angle. What is this called as angle of Louis? Okay, So this is these are few things which because actually I want to just remain till assessment. So just a second. So what are different tests? Okay, now if we just think about the tests we do for so one of them is Malampatti. Okay, there are different ways to memorize it and tell it PUSH. Sometimes they tell it as PUSH. If you can see all four things. It is Malampatti 1, and then 2, and then 3 and 4. Like this is pillars, this is uvula, this is soft palate, and this is hard palate. So this is you might find it in a different ways. This Malampatti. Okay. What else? What about these distances? This one, thyromental distance, sternomental distance. Okay, mandibulohyoid distance. How you do it? Actually, to be exactly, you should be knowing how sensitive these tests are. Its name is Patel's test, thyromental distance. It should be like more than 3 fingers, or if it is less than 3 fingers, you are expecting difficult intubation. Okay. Similarly, this Sawa test for sternomental distance. Okay. And mento higher distance. You should be just interpreting that if, for example, these distances are less, you are expecting difficult laryngoscopy, difficult intubation. Okay. You know about this Lemon law? Yes, Atik bhai.
Sir, in the lemon, we look for sir, some radiology, some distorted anatomy, some compression, external compression, and then we have to evaluate the mouth opening by 3 finger breaths, and we will look for Malampatti for M. And sir, from O we see the obstruction by just see the just you as you told like tonsils, kissing tonsils, or some other extraction, or sir, in the last for N it is neck extension.
Yes, you generally evaluate by evaluating by 332. Okay, and then Malampatti, obstruction, any condition which can cause obstruction, and neck mobility. Okay. There is another, this is score, Wilson's risk score. I think it should be here. Wilson risk score, you remember?
So it is same like Malampatti, but we compare it by looking at the vocal cord with the naked eye.
No. Wilson's risk scoring system is alag, Atik bhai. It has a component of weight, neck and jaw movement, mandibular recession, and buck teeth. And if it has more score, it is associated with difficult intubation. Okay. Wilson's risk scoring system. It's not written here, but it you will find it in some other source. Just a second. Just for you, I will just try to focus here for the we have up to now discussed some points about history and examination. So we will be think about anything which is related to making difficult airway. mask ventilation, intubation, laryngoscopy, and then we will be doing some examination. One of them is Malam Patti. Okay, then we will be assessing the cervical spine mobility, occipital and atlantoaxial joint mobility. Okay, patient is asked to extend the head. Okay, then thyromental distance, sternomental distance, prayer sign. Prayer sign is being done to see any glycosylation of joints as occurs in diabetes. That this will be just a predictor that patient's joints are stiff and may not be able to be ventilated. Okay. Okay. Then Wilson risk score, as I was telling you, it is related to weight, head and neck movement, jaw movement, receding mandible, buck teeth. And it will be predicting about 75% of difficult intubation. Okay. And you should be knowing the sensitivity. You will find in some books exactly percentage of sensitivity and specificity, because they can ask you in MCQs. This is just a task for you. Just try to find it out. I think it is written in Oxford, if I'm not wrong. Maybe you will find it on Oxford, or you can search that what is the percentages. If I find, I will share with you. Okay. Investigation, I'm leaving for a while. And we will just, because here in this text, they have, because this book is old one. Okay. So Das algorithm is old. This is old algorithm in this book. So you have to follow the latest Das algorithm. Okay. So okay. I was just looking here, these are the new things which they can ask you. They point of care ultrasound, focus. So they are assessing the, even in difficult airways, or in if you have the chance to, if you have the facility, you can even confirm the endotracheal deep position, and like you can measure a number of things by, like you see, they have written here, point of care ultrasound can also be used to assess subglottic diameter of trachea. Okay, this can be performed even in children to estimate the tracheal tube size. So this is future. I'm not, have any one of you seen people doing it? This is actually future. And I wish that all new junior anesthetists, presidents, they should have this facility that they learn it. These are new things. Sound is being used definitely. Okay, so other now if we just have a look at some of the investigations. So investigation, usually we can do chest X-ray. Okay, chest X-ray. What findings you can give related to airway in chest X-ray? Plain chest X-ray. Yes, please. Yes, Atik bhai. Anyone? Mozama? Arfa? Anyone wants to speak out?
Sir, atlanto-occipital joint, we can
Sir,
see on
what do you want to? What do you want to?
neck X-ray.
Chest X-ray. Plain chest X-ray. What information you can get from chest
Sir, any
X-ray?
mass?
Okay.
Sir, about the trachea, sir, about the trachea.
Let him speak now. Yes, Dagam, please continue.
Sir,
Mass.
any mass?
Mass usually with reference to trachea, as Atik bhai was saying, that there you can see tracheal deviation. Plain chest X-ray, you can see tracheal deviation. Okay. Then this neck X-ray neck, you can see the tracheal compression. Okay. If there is tracheal compression, you can assess tracheal compression. what you get in on, of course, CT scan or higher investigation will be telling you even more details. Nase endoscopy, what can you get? Yes. What information? Because before, traditionally they used to do this indirect laryngoscopy. Okay, they used to do indirect laryngoscopy, but now recently, if in especially with reference to thyroid disease, what information you want to see if you when you are doing nase endoscopy? Anyone, please?
Sir, we see the Balampati score, and we see the vocal cords, is it moving or not moving, or and see the mass, anywhere mass around that the tube can go, and if it rigid, Balampati score will be rigid or not.
No, Atik bhai, just correct few things. Malampatti is something else. When we are doing nase endoscopy, we are visualizing the directly, especially we can see the vocal cord movements. Okay.
Vocal cord movement, sir. Vocal cord movement.
Yes.
And sir, we as a whole, we are looking at the posterior pharynx, and we see all the things, and we see the vocal cord as well, sir.
Yes,
maybe
we can allow.
Maybe.
Yeah, we can do any pathology. We can see deviation, and it is also a medical legal thing. That because after you give some muscle relaxation and everything, the vocal cords will not move. Okay, so whenever they are doing thyroid surgery, they have this nase endoscopy to document how is the movement of vocal cord before surgery. Okay, so nase endoscopy is for this purpose. Okay, so CT scan, of course, will find the exact if it in detail, especially compression, retrosternal, things like that. Okay. Okay. So lateral cervical with head in neutral position, close is required for the measurement. They do this measurement. Atlantoaxial. Actually, I'm not very good in radiology. If anyone has this experience, he can share. But usually, the information which you can get is, of course, subluxation. You can be diagnosed atlantoaxial subluxation. This compression. Okay. There you see, this is another thing which they have written here. Palm print in diabetics. The patient is made to sit.
This has been asked in CPSP, sir.
Yes. Palm and
print and prayer sign.
Yes, palm and fingers of right hand are painted with blue ink, and then presses the hand firmly against a white paper, and then they grade it. Okay. What else? Predictors will be poor flexion, extension, mobility of head or neck, a receding mandible and presence of prominent teeth, reduced atlanto-occipital distance, a reduced space between C1 and occiput, large tongue size. Okay. Yes, mouth opening as and also this upper lip bite test. Upper lip bite test will tell about if there will be receding mandible, patient will not be able to bite the upper lip. Okay. I will share this data and you can read more details about it. You see, can the patient open mouth widely, indicative of TM joint? Okay. And there is any pain, you will also come to know. Can the patient maximally protrude the tongue? Impact posterior aspects of mouth, pharyngeal structures. Patient ability to move jaw forward indicates easy to maneuver the laryngoscope. Can patient fully bend, extend the head and move it sidewards? Indicates neck movement. Okay. Okay, so I will finish.
Sir, before doing all these tests, you should ask the patient if you have got any pain in your neck.
Yes, of course, of course. Actually,
Sir, sorry, sir, I was mixing the between Cormac Lane grading, sir.
yes,
With
yes, yes,
Wilson.
Wilson, I understood, no problem. Inshallah, we will do next topic. Actually, airway I have done in detail before, and you can find this in the channel, and if you go to playlist, okay, and then you will find here a playlist of airway. So in which actually it was early days, and we discussed in detail around in 7-8 session whole about this airway. So I will suggest you to have a look. Okay, you will find this, because before we used to do it in our native language. So unfortunately, some of you will not be able to understand it, but majority of them are in English recently. Okay, so inshallah, we will meet again tomorrow. Okay. Anything because actually, I just started this book, and I'm just trying to transversely dissect. So tomorrow we will continue here, airway blocks in context of awake fiber optic. Okay, so we will just try to continue, because there will be this topic, and then what is the next topic? This is not related to it. I will just
This
try
awake
to.
fiber optic, sir, this awake fiber optic is also important for talks and for MCQs and for Viva 3.
Yeah, this question. I think nobody can pass any anesthesia exam without this topic of awake fiber optic. Okay, so thanks a lot, all of you, for your presence. And anyone can ask. Dr. Humaira, your question I will answer. Okay, anyone wants to ask any question, just feel free to drop a message on WhatsApp. Okay, and I will just try to answer. Even someone wants to discuss any topic, you are welcome. Okay, anyone want? Because I was just thinking, I have discussed a number of units thoroughly. So now I was just thinking to dissect in a slightly different way. Okay, so I just started with this book, but we will just inshallah continue because my aim is to give you a concept. You can read everything yourself. You all have the guts to do it. Only that sometimes you are not getting the main points. So whenever, like for example, if someone is asking, like a gentleman who was here, we started from the tests. So whenever they are asking you about assessment, you should be starting from history. So that should be message for you. Assess history, then examination, then investigation. And the other thing, which the message from whatever we have discussed, all of you have read these things multiple times. So what's new? So you should be knowing the sensitivity and specificity. What are the advantages of doing different tests? Okay. So thank you very much. Inshallah, tomorrow we will continue. Bye bye.